Welcome. I'm Daniel Koritskis, Chief of the Division of Infectious Diseases at Brigham and Women's Hospital and the Harriet Ryan Albee Professor of Medicine at Harvard Medical School. And it's my great pleasure to welcome you to today's program, Lessons Learned from the Pandemic, Redesigning Clinical Care, Research, and Public Health. Let me give you some information about our program. Over the next 2 days, we'll be talking about some critical issues related to the response to the COVID-19 pandemic and how we deal with pandemics that may come in the future. We'll have 2 sessions today. The first session, what went wrong and what we did right, and session 2, the health system fights back. Tomorrow, we'll have 2 more sessions. Session 3 will be no one is safe until everyone is. And the final session, are we ready for the next pandemic? During the program, we really look forward to your active participation as audience members, and you can submit your questions through the live Q&A widget. We'll be forwarding the questions to our moderators who can address them to the speakers during the question and answer period. If you have any problems that require technical assistance, just click on the live support icon and we'll do our best to help you. I'd like to acknowledge the generous support of Moderna, whose unrestricted grant made possible this medical education program. I'd also like to acknowledge our various endorsers who are shown on this slide. It's now my pleasure to turn to my co-chair, Professor Kazatchkine, and ask him to introduce himself.
Thank you, Dan, and welcome to all. My name is Michel Kazatchkine. I'm currently with the Global Health Center at the Graduate Institute for International Affairs and Development in Geneva, Switzerland.
And I'd like Professor Lazarus to introduce himself as well. He's participating with us virtually.
Thank you very much. This is Jeff Lazarus dialing in from the Barcelona Institute for Global Health here in Spain.
This program would not have been possible without the participation of an outstanding organizing committee. In addition to my 2 co-chairs who've just introduced themselves, I'd like to mention Dr. Nicole Lurie from the Coalition for Epidemic Preparedness and Innovations in the United States, and Dr. Jonathan Shapiro from the National Hemophilia Center at Sheba Medical Center in Israel. Please participate in the post-meeting survey after the workshop. Your feedback is vitally important for us in order to improve on this program and in order to meet your needs. A certificate of attendance will be sent by email upon completion of the post-meeting survey. Well, let's get right to it. Let me go ahead now and start with the first session, what went wrong and what we did right. And it's my great pleasure to introduce our first speaker, Professor Elena Lehido Quigley from the National University of Singapore, as well as the London School of Hygiene and Tropical Medicine in the United Kingdom. Professor Higley is a professor and chair in health systems at Imperial College and the George Institute for Global Health in the UK. She has extensive expertise that extends across diverse regions, including Europe, Sub-Saharan Africa, Latin America, and Southeast Asia. Her research has significantly advanced global health, and her most recent work delves into critical topics such as pandemic preparedness and response, as well as the evolving landscape of global health architecture. We'll be hearing today from Professor Lehido Quigley about how did the health disaster lead to a major social and economic crisis. Professor Lehido Quigley.
Thanks a lot for the introduction, Daniel, and thanks a lot for the committee organizers for inviting me to this event. I'm very honored to be able to present today. So as you see from my title, I'm going to be focusing on how did the health disaster lead to economic and social crisis with the pandemic. So what am I going to cover today? So I'm going to mention very importantly that I'm going to speak through a lens of health systems and health policy. I will mention briefly the independent panel, which some of the speakers and the organizers of this event were part, and I was helping with conducting the research. We will talk about recommendations that we made at the national responses, and I will spend a bit of time talking about some of the health systems challenges that would also be helpful for the second session. And then finally, how can we reimagine the health systems of the future, and what type of work can we do next as researchers? So before we move into what went wrong, very important to highlight, and I think sometimes we forget, that for pandemic preparedness and response, there are different phases. And we actually had an incident, which was COVID-19, and all countries went into the response phase. But it seems that the countries and also some governments have forgotten that we do have other phases that we need to take into account, and that actually are really important. So now we have the recovery phase. You can see there we also have the prevention and mitigation phase, and then the preparedness phase that will lead us to be prepared for the next pandemic. And what is very clear now, and I think most experts agree, is that we are lagging behind in this phase of preparedness. Now, I just wanted to highlight a bit where my work is coming from. So when, I'm sure you all can think the moment when everything started where you were. In my case, I was in Singapore at the university, and it was very clear that in Singapore, very quickly, we soon realized that we had to put measures into place, and my whole team was moved to doing research, and as I said, from a health system perspective, and you can see there, we were very keen on providing evidence in different countries, particularly on how the system was resilient or not, and providing recommendations. So one of the key papers that we published that you can see there, the title reads, "Are high-performing health systems resilient against the COVID-19 pandemic?" And this was before the closing of most countries. And we were already suggesting that perhaps some countries, such as European countries and the US, would not be prepared, and we were already giving recommendations from Hong Kong, Singapore, and Japan. Now, very clearly, when we were starting with the independent panel work, we were looking at the Global Health Security Index, some other indexes and indicators, and what we also realized, and here, during my presentation, I'm also going to be critical with ourselves, researchers, so we can learn lessons for the future also. So we were very clear that some of the indexes that were designed to suggest whether countries were prepared or not, they also failed in the sense that they were not able to predict, they did not have this predictive power. They were not able to predict which country was better prepared or not. And you can see there in the map some of the countries that were highlighted first and second. I'm not going to name any of the countries, but you can see that they were not as prepared as it suggests. With the independent panel, it was very clear for us that we wanted to collect the evidence, and I focused very much in collecting evidence in 28 country responses. But I also want to highlight, and I'm sure Anders Nordström will mention that for us was very clear also to document the chronology of the response, and we identified all the crucial moments in the first 3 months to suggest what went wrong. So very briefly, what we identified that went wrong was, first of all, there were delays at the international level. Secondly, there were delays at the national level and some of the key institutions, but above all, what we identified also was that most countries, and there are some exceptions, they had a wait-and-see approach, and they took more than 1 month to react. And that was one of the key components that we want to avoid for future crises. Now, you see here the analysis of the 28 countries. You can see we had a variation with all the continents included and different mortality rates and different sizes. And when people ask me, so what are the countries that did best? So I want to show the next slide that highlights how difficult and how complex it is to suggest which country did better or not, because it depends on multiple factors. And we also realize the importance of context. So you can see there some of the key components, so which control strategy, governance approaches, what public health measures they chose, and the inner and outer context are key. So we need to consider that when we look at which countries did well or not. Having said that, we were able to identify some key aspects. So here we look at a paper that we published in Nature on health systems. And one aspect that I want to highlight of this paper, while we go through service delivery, governance, and all the different components, we also highlight very importantly that activating our response, readiness and being prompt was key. Being able to adapt your health system was also very important, and then being able to preserve your functions. And a key component that was highlighted in all the countries is that being able to reduce vulnerability of those that needed help in those moments. The next slide highlights, and for me this is one of the most important slides, it's very crowded, but I want to highlight some of the key components that we identified for high-performing national responses. So the first one, we identified that. And having said that, while we did identify some patterns, there's always exceptions. So it's very difficult to conduct an analysis of this type. So we did identify that having prior experiences in pandemic preparedness was key, and having these plans, but equally important was implementing those plans. So only having a plan was not sufficient. What became very clear, and I think this is a key message for moving forward, is that leadership and trust in the decisions was key. And what we know now is that many countries did not show great leadership, and that had a really influence in the response. And together and coupled with leadership is listening to scientific advice, trusting scientific advice. And when we look at leadership also, we identify that those leaders that were empathetic, they were willing to listen, they were willing to change track when errors were identified, and they were even willing to ask for the population that they had made a mistake, recognize mistakes. They actually, that had a very positive impact in the sense that populations trusted the leaders, and therefore they trusted the measures that they were implementing. Of course, having a strong health system is key, and we know particularly in Europe, with austerity measures, some countries were very depleted. And then also, in some countries, public health has been underinvested, and this is a key aspect. Having said that, those countries that introduced, and again, I emphasize, promptly, proactive testing and contact tracing measures, and those that had quarantine and isolation facilities very, very promptly, they did much better than others that took much longer. But the key aspect for us is also social and economic support, which means that providing social and financial protections for communities and those that are vulnerable, and also for small businesses, and for vulnerable populations to be able to fulfill the public health measures that were implemented. Now, looking at recommendations, if you see, when we did this report, we were focusing very much in terms of the react phase. So we designed this iceberg, and we were looking at the top. But we were saying that we really need to pay attention to the bottom of the iceberg. So we need now to prepare our systems. We need resilient health systems. We learned that we need socioeconomic supports and public health measures. We need to strengthen UHC. And we need to monitor and evaluate our responses. We emphasize the importance of monitoring and evaluating, and some countries have done it, but many others have turned the blind eye and moved on. And we have to emphasize that we need to learn from these experiences. And then we even refer to at the bottom of the ocean, the need to transform societies. Unless we build equitable societies and shift mindsets, we won't be able to be prepared in the future. Just to highlight that this work we conducted, we've got several papers that will be discussed in these sessions. We've got some on vaccines that will have Els Torell talking about it. But we also were very key of the importance of involving the community, and also discussing issue of trust, and also discussing those components that are normally left behind and that they were not included during the pandemic. So here you can see we have a paper only talking about those qualitative components for evaluating pandemic responses. And by that, I mean, we need to look at cross-border cooperation. Most of the time, we focus at the national level, sometimes at the local and local level within the national system. But it's been very difficult to make those connections. So we need to learn from other countries, and we also need to link the national with the international level. Of course, I've already said the importance of national governance, leadership to guide the responses, and also a key component, and I think it's a learning lesson that we did not take so much into account at the time that we were doing it. We were looking at mortality rates, but right now I think we want to do another analysis, and we need to look not only at mortality rates, but how societies were left after the pandemic. Are they more divisive? Are they more cohesive? These are very important components. And of course, how were economies left? We need to do much more work on that. And what we all know about, how it has affected the mental health of the younger population, the older population, how has it left our society? So I think we need to take that into account. And above all, you can see there, we need to take special attention to inequities within countries. So just to give you an example, Singapore was very successful. Everybody considered it to be one of the best countries in terms of responding to pandemic preparedness and response, but they did not pay attention to migrant populations because it's an area where it was neglected. So this is an area where when we want to look at inequalities, these groups need to be included and they need to be within the system and they need to be provided with care. This is only an example of what I refer to as paying special attention to inequalities. So now, how can we prepare our health systems? I'm just going to give a couple of ideas, because I know we have a session afterwards, but this was coming very strongly from our analysis, so I think it's also worth mentioning. So first of all, we've got if we really want to have resilient health systems, they need to be complemented with a multi-sectoral approach. We have to move beyond health. We've said that I'm a health systems researcher. We do need to move beyond health and consider economic and social components. We've learned of the importance of a whole-of-government approach. I cannot emphasize more often good leadership. And the next step, we also need to take care of our healthcare professionals. We are very worried that we need much better planning because a lot of them want to leave the profession and many countries are finding it difficult to recruit them. So a lot of effort needs to be put into that and also taking care of their own mental health. Of course, we will have a session on medical products, but we need to design a system that is equitable. We are very clear that we need an integrative approach. We need to integrate primary health care with secondary care, but also with public health and also with social and home care. Many countries really struggle on that front. And then we need to open a debate in terms of appropriate financing for health systems. And finally, this idea of partnerships. We need a co-production approach where the community is much more involved and not in a tokenistic manner. We need approaches where we truly engage patients, healthcare professionals, and communities. As I said, governments need to have a national, subnational, and direct resources to health and to take into account social and economic conditions. My final 2 slides, just to highlight that we are also proposing reimagining. This is a very big opportunity that we have now. And I tend to be very optimistic in the sense that we need to reimagine our health systems. And I do think that most countries have realized that we need to reform, we need to strengthen. And this is an opportunity for health systems researchers. So I think we need to really think together, how do we want to reimagine the health systems of the future? And there I make some proposals that we wrote for the Health Systems Alliance, which is merging this idea of health systems with health security and healthy populations. Again, a much broader perspective of health, discussing it in the context of systems for health. The role of scientific advice. The role of scientific advice doesn't stop with the phase that I've mentioned. We have to continue working. So as researchers, I know we are all tired that in a way maybe we want to look at other topics, but we now have this opportunity to reform our health systems and also to prepare for the next pandemic and to conduct the research that will guide us better for future risks. So in that sense, I just want all of us to think a bit, how do we want to contribute? How do you think we can contribute? In my case, and together with some of our speakers today, including Professor Kaczynski, we thought that the best way that we could contribute in our work is now, I've said at the beginning, we failed at evaluating and monitoring which countries are prepared or not. So why not propose a new way of monitoring and evaluating, but this time doing things differently? Rather than a top-down approach, why don't we do a bottom-up approach with grassroots indicators, involving the community, involving patients, listening to all the stakeholders, and coming up together with some solutions. So with that thought, I leave you thinking about how you can contribute, and I thank you for your attention. Many thanks.
Thank you so much, Elena, for that really brilliant overview. That really helped set the stage for the rest of our program. It was just spectacular. It's now my great pleasure to introduce Anders Nordström from the Swedish Ministry of Foreign Affairs. Dr. Nordström, since 2010, has been Swedish Ambassador for Global Health at the Ministry in Stockholm. He is currently a member of the Alliance for Health Systems Research Board, the Chatham House Commission for Universal Health, the International Vaccine Institute Global Advisory Group of Experts, and the Virchow Foundation for Global Health Council. He's had many leadership roles at the World Health Organization. Among his many accomplishments, he served as the interim executive director. He established the Global Fund to Fight AIDS, Tuberculosis, and Malaria as a legal entity 2 decades ago. And most recently, he headed the Secretariat for the Independent Panel for Pandemic Preparedness and Response. Dr. Nordstrom is going to be speaking to us today about the failure of global, regional, and national governance. Anders?
I'm delighted to be with you to share some reflections about global, regional, and national governance, what we saw from the COVID-19 pandemic in terms of failure. But let me also say from the very beginning, it was not just failure that we experienced across the world. We saw a lot of hard work, and we saw also a lot of success. Very much historically compared to what we've seen in the past. What I'm going to share, and what you also heard from some other speakers during this meeting, what something called the Independent Panel on Pandemic Preparedness and Response found. This was an independent high-level panel that worked during 2002. I had the privilege of being the head of the Secretariat, and a lot of the lessons that not I'm just going to refer to now, but that many people are referring to, came out of this work. So this was a systematic review of what we can learn from the outbreak of the pandemic after the first 9 months. So just to share with you a couple of the high-level big picture lessons. The first one, when it comes to how the international system worked and how national government worked, and also how the interactions took place in between national government, regional structures, and the international system, was that despite warnings and clear lessons learned from the past, the world was not prepared. There have been a number of reports and commissions presented telling the world that this was going to happen, but also with clear recommendations in terms of what needs to be changed, and still the world had not taken action. So that was one of the first lessons, that the world has not taken note and learned from the past. The second one, when it comes to the international system and the interaction again in between national, regional, and global structures and governance, was that the reaction, the speed in terms of how things happen, was too slow. Not necessarily the very first initial reaction that came then from the government of China during the very first days when the first cases were found in Wuhan. That was actually quite okay when it came to time, slight delays. A larger, a more substantive delay happened in January when the International Emergency Committee was going to advise the Director General of WHO whether to declare a public health emergency of international concern or not. Then there was a clear delay. So that was basically the whole month of January that was lost before that message came to the world. But the big delay was basically then during the month of February, meaning that very few countries actually reacted when the Director General of WHO said, we have a big problem here. So the alarm system, the international governance in terms of them being providing direction to the world, did not work well enough. And that was part also of the conclusions, recommendations, what needs to be done now for the future. If we look then more specifically at the national level, again, drawing on the work that was done by the independent panel, we did 28 country studies, not in order to rate or to rank countries, but to learn from the 7 best cases and the 7 worst cases. And then we had 16 countries in the middle here. What did we find in terms of main sort of conclusions? If we look specifically then around governance and leadership, the low-performing countries, and I think I can name them here, the US, the Brazils, and countries like that, that initially had a very inefficient, ineffective response. There were some common themes here in terms of governance. First, I mean, the whole situation was devaluated, was regarded that non-existing, even denial. There was a lack of coordination in between different levels of the government. There was a refusal to take the serious and to take actions. There were delays, and there were also politicization of the situation. So this became even party politics in some countries rather than treating this as a public health emergency. On the contrary, some of the high-performing countries, and here you had some of the countries in Southeast Asia or in like South Korea, Singapore, Thailand, you saw some very effective response. There was an engagement of partners in the countries, was cross-government work, there was good coordination, it was not only the Minister of Health, but also other relevant ministers. There was an approach to develop and to strengthen tools, whether it was to provide financial support or to refine the policies that were in place. So there were some good practices and there were some bad practices when it comes to governance at the country level. Moving then to the regional level, I think the most striking lessons here from the pandemic, from the COVID-19 pandemic, what was happening in the European Union and in the African Union, and also the interaction in between those two regions. Of course, what was in the focus of this was access to vaccines. What was interesting here was the different approaches and what happened over time when it came to the political commitment and also in terms of taking responsibility, which is part of governance there. The European Union were very ambitious very early to ensure that they would basically safeguard access to the vaccines through entering into contracts with all existing or known potential vaccine producers. And they did not only enter into contracts for the total population of the European Union, but 5 times as much vaccines as was actually going to be needed for that part of the world. And the US and Canada and a couple of other countries did the same, taking no risks. The implication of that was, of course, that the possibilities for other countries, including also for the global mechanism COVAX, to enter into contracts at competitive prices were quite limited because already all the space was taken by the European Union and others. But what happened here over time was very interesting to see how both the African Union then were really strengthening the African CDC, but also the political will and governance from the African side saying, this is not acceptable. We will raise our own resources. We will set up our own vaccine platform. We will ensure that we are actually getting the vaccines also to our populations. We will not only depend on the willingness from some other countries to donate a bit of vaccine to us. There was a very interesting dynamic here in between different regional bodies. And I think for the future, this is important that we will have stronger regional bodies when we are going to see how we can get and how we can strengthen the international system also to be ready for the future. But interesting dynamics both within and in between those regions. Global governance, if we look at the global level, then of course, I think we all remember at the very beginning the quite difficult conversation in between the US and China. This basically meant that the world could not come to, in some way, strong and responsible leadership to see how one would manage this outbreak. US blaming China for not being transparent and not sharing information, and China, of course, not being very happy with this. And also, I think we still remember President Trump, how he came out very clearly to say that I don't believe in WHO, we are basically going to leave that organization. All of this has to do with generating mistrust, which was not the best thing to do when we had a global crisis. So we saw that at the very beginning, and we did not have a good platform for how and where to make sure that we can get good political governance and responsibility at the global level. And this continued when there were discussions in the Security Council in the US, in the United Nations. One couldn't come to an agreement in terms of one of the security resolutions because of the mentioning of WHO. US refused to actually refer to WHO, which is, looking back, it sounds totally unbelievable. But that was the case. So there was not really a platform where you could have global political negotiations and discussions. G7 at that time, then chaired by Germany, now lately by Japan, and the G7 at that time by Indonesia, and now by India, are important platforms, but they are not formal governance bodies. They are informal constellations of countries, very important and can be very useful, but also both the G7 and more importantly the G20 have not been able now to come to very firm and concrete decisions, partly because if you think about the G20 and the political dynamics with Russia, China, the US, and some of the other countries. So a very difficult political environment. So the global governance, or the governance at the global level, have definitely not worked in a perfect way. We see that also now in Geneva, when the negotiations have started on a new global treaty, a new set of global rules for how we're going to be more safe in the future. Those negotiations should be ready May next year. They have basically not started. There's a lot of discussions, preparatory work, but real negotiations and being close to actually having the new legal instrument in place, there's a long way, and there are big tensions in between different groupings and in between different countries. Now, in New York, there are 3 high-level meetings that have just happened on tuberculosis, on universal health coverage, and on pandemic preparedness and response. Again, the independent panel made some very clear recommendations here in terms of make sure we have a new legal framework, make sure we got more financial resources, a stronger WHO, a new platform for having access to vaccines, but also an independent governance and monitoring of how the international system is performing. Will the world have taken decisions on those now at this high-level meeting, the opportunity now that countries have coming together and take those decisions? No, unfortunately not. The world, as the panel was saying in their report 1 year after their initial report, is the world really transforming, or is the world still tinkering? And the answer is very unfortunate. The world is still tinkering. So we still have big challenges here in terms of all governments across the world taking responsibility. So in the nutshell, unfortunately today, there's more failure than success. Do we need then to be totally pessimistic about the future? I hope not. And we'll finish just with one slide looking back, remembering that it is actually possible to tackle also big challenges and the big emergencies. And if you look at the United Nations, looking back now 22 years, we established the Global Fund. We had a special session of the United Nations in the year 2000, where the world agreed on a set of indicators and targets for what to do about the HIV/AIDS situation at that time. Those indicators, that agenda, meant a lot for the world, as well as the establishment of the Global Fund in the year 2002. This is now Kofi Annan, who was the patron, Christos Kionga, who was the first chair, and I was the interim executive director for the secretariat at that time. Looking back and looking at the actual results, I still feel optimistic that, yes, we have a difficult political situation today, both in many countries, national level, in regions, and at the global level. But if we look back to see that, yes, we could tackle and manage a big challenge at that time, and I'm sure we will be able to do that again. Thank you.
Thank you so much, Anders, for those crucial insights. That was really very illuminating. It's now my pleasure to give the next talk, What Did We Do Right? A Perspective from the Global North. You've heard already in the first 2 talks that there were many things that we did wrong, and I think it's important that we acknowledge those mistakes and learn from them. But it would be a mistake not to also acknowledge that some things went right. Now, I don't at all intend to imply that the things that were done right were distributed equally or equitably, or that they couldn't still have been done better, but we should at least acknowledge some of our successes. These are my disclosures. So I will quickly, in the next 10 minutes or so, review what I think, from a biomedical perspective particularly, was done properly and done throughout most of the North. And this included the application of molecular epidemiology, infection control, healthcare mobilization, diagnostics, therapeutics, the implementation of randomized clinical trials, the development of vaccines, communication, and community engagement. With respect to molecular epidemiology, there was rapid sharing of sequence information from the original Wuhan SARS-CoV-2 strain that enabled the development of both molecular tests and vaccines. Indeed, within a day of the sequence first being released, several manufacturers around the world began work on a vaccine. The sharing of sequences through GESIDA ensured global access to these sequences, and the development and then propagation of full-length sequencing of SARS-CoV-2 allowed identification of novel variants as they arose in near real time. Quantitative sampling of sewage allowed prediction of trends in clinical cases, often predicting when there would be upswings and downturns in COVID-19 as the pandemic rolled out. And at times, the sewage itself could be used to identify novel variants. There were many things done correctly with infection control. The masking of staff and patients sharply curtailed nosocomial transmission. This was clear in my own hospital. And COVID-19 incidence among hospital staff was consistently lower than incidence in the community at large. PCR screening of patients for SARS-CoV-2 allowed isolation or cohorting of patients as appropriate, further reducing the risk of acquiring SARS-CoV-2 among vulnerable patients in the hospital settings. And the use of appropriate personal protective equipment and its reuse, the extended use of PPE as appropriate to augment supply when the supplies were tight, was another rapidly implemented innovation that helped to keep the hospital staff protected. Widespread adoption of masking contributed to lower rates of COVID-19 in communities with high adherence to masking, but as we know, the adoption and adherence to masking was really quite spotty and therefore can only count as a partial success. And then improved ventilation and HEPA filtration played a role where these innovations were actually implemented. What about acute care for hospitalized patients? Hospitals in the North mobilized rapidly to expand the number of intensive care beds. Staff redeployed to support the demand for ICU care. In my own hospital, which has approximately 600 beds, we ended up having approximately 100 ICU beds, which was a five-fold expansion in the number of beds that we typically have. The creation of field hospitals to meet the demand for beds expanded this capacity as well. Within hospitals and hospital systems, a centralized coordination of efforts through incident command structures played a vital role in assuring the coordinated function of each component of the hospital and of the healthcare systems. The pivot to virtual patient encounters for non-acute outpatient care was an essential adaptation that allowed for ongoing care of people not able to access care in their usual settings. And the commitment of staff to provide care despite the risk to themselves really needs to be acknowledged, both for the heroism of those staff and for its impact in our response. The rapid development and deployment of validated molecular tests, both by PCR and then later through point-of-care antigen detection for home testing, was a critical innovation that really made a crucial contribution to our ability to identify who had SARS-CoV-2 infection and when people might be able to return to the workplace. The availability of testing enhanced our surveillance and infection control efforts, and semi-quantitative PCR tests became important laboratory markers for early phase testing of antiviral therapeutics. Turning to therapeutics, the rapid development, testing, and deployment of therapeutic interventions was really extraordinary. This included not only antivirals such as remdesivir, the combination of nirmatrelvir and ritonavir, molnupiravir, and various generations of monoclonal antibodies, but also immune modulators, including dexamethasone, tocilizumab, sarilumab, baricitinib, and so forth. The use of various mechanisms to accelerate the regulatory authorization, such as emergency use authorization in the US, speeded access of populations in the north to these important therapeutic interventions. And government purchase and distribution of these agents also assured widespread access, although frequently in an imperfect way. I can't stress enough the importance of randomized clinical trials. The rapid design and implementation of such trials, particularly the development and implementation of platform trials, provided crucial evidence that was essential to guiding our therapeutic management of SARS-CoV-2 infection. Often these trials leverage national infrastructure, such as the National Health Service in the United Kingdom and the National Institutes of Health clinical trials networks in the United States. There was also the innovation of implementing remote trials in the outpatient setting, studies where no participant ever had contact with any investigator in a face-to-face setting. And the importance of negative trials in curtailing the use of ineffective agents cannot be overestimated. And I'll just show two data slides here. First, this is the study showing the importance of dexamethasone in reducing mortality, which came from the recovery trial, one of the first studies to show a mortality advantage. And then this series of negative trials looking at metformin, ivermectin, and fluvoxamine as ineffective, helping us to direct our efforts and focus our efforts on the truly effective interventions. Now, of course, the most important advance and the greatest success was the development of vaccines. One can't underestimate again the importance of the basic science work that laid the groundwork that made rapid development of SARS-CoV-2 vaccines possible. This included the development of RNA vaccine platforms and the adenovirus platforms. It also included work that had been done in other viruses, understanding the importance of the locked conformation of the spike protein as by analogy to work that had been done with RSV and with HIV. There was also the importance of private-public partnerships. Many of the trials that went forward to validate the vaccines and to demonstrate their efficacy were done with government funding that augmented the funding made available by the pharmaceutical companies or vaccine developers that had initially discovered these vaccines. There was also, as has already been alluded to in the previous talk, the importance of advanced purchase commitments to de-risk the trials and to de-risk manufacture. By committing to purchase vaccine, without knowing what the outcome of the trials would be, meant that once a vaccine trial demonstrated efficacy, there was already sufficient supply available to begin its distribution and implementation. Again, that was not a perfect distribution because it focused principally on those countries in which these trials were conducted, but it certainly accelerated the widespread availability of vaccines in the global north. We heard in the previous two talks as well about the importance of communication, and there were many examples of timely, understandable, and evidence-based messaging, which unfortunately were all too often muddied by politicization of those messages. But public access to COVID-related publications by the major medical and scientific journals was really an important benefit that really accrued internationally. There was also, for the most part, at least in the United States, frequent, generally accurate reporting by what I would refer to as the mainstream media, venues like the New York Times, even the Wall Street Journal, CNN, and most of the local media, as opposed to the fringe media who continue to confuse things. And as Anders mentioned already, it was important, and as Elena mentioned as well, it's critically important to be preparing the public for change because we were learning as we went, and it was inevitable that there would be mistakes made that needed to be corrected. And this frequent appearance of scientific experts and local health experts on local and national media helped to convey those messages. There was also, and still remains, the need for effective means to counter disinformation. Lastly, one can't stress enough the importance of community engagement. It's essential to engage community in all aspects of the pandemic response, to have culturally appropriate communication, to partner with community to engage marginalized persons, and to address stigma, which became so important in convincing individuals to accept testing and to accept vaccination in order to be able to control the pandemic and to reduce the number of cases. The very last point, which I realize I hadn't included since my perspective is largely biomedical, but the comment by Anders in his talk reminds me of it, is that in many countries in the North, the countries did provide economic support for those segments of the economy and for those industries that were most hard hit by the pandemic in order to sustain individuals throughout the period when there were shutdowns in place and people were unable to work. Those could have been done much more effectively and more broadly, but they did help prevent a more general economic collapse in those countries where these interventions were available. So with that, I'll thank you for your attention to my talk, and it's now my pleasure to introduce our next speaker, Dr. Viraj Tangcharoensatian, who trained in medicine at Siriraj Hospital and Mahidol University. He served for 10 years in small rural hospitals at the Thai-Laos border. He's received the Edwin Chadwick Medal from the London School of Hygiene and Tropical Medicine in 2011 for his contributions to improving health systems in the interest of the poor. He also received the Sam Ajay Distinguished Public Service Award by the Alliance for Health Policy and Systems Research and Health Systems Global for his engagement in health systems development and research. And his scholarly contributions include over 300 international peer-reviewed publications. Viraj is going to talk to us about what did we do right from the perspective of the Global South.
Good morning, dear colleague. I'd like to present this piece of work on what right things we did during the pandemic. These are the objectives. This short talk will reveal what right things country apply during the inter-pandemic period and during the pandemic phase. We analyze and synthesize evidence from published literatures, which contribute to a substance and content of this talk. During the inter-pandemic period, many successful countries have strengthened their 13 core capacity as required by International Health Regulation 2005. Many countries improved their preparedness capacity, notably One Health integrated surveillance, with an aim to detect zoonosis with pandemic potential. Many countries improved the capacity on genome sequencing and sharing this information for international partner, WHO, and many others for risk assessment, which trigger development of pandemic response products. Many countries apply field epidemiologist training and also support public health officers for event-based surveillance. Some countries has developed their own surveillance and rapid response team, which is responsible for daily local outbreak detection and control. This is what Lucy Gilson defined as everyday health system resilience, so that a small outbreak can generate capacity and for a more larger epidemic and pandemic. Many countries has strengthened their health system resilience. Helena, who is one of the panelists here, this is her paper. She talked about high level of surge capacity, functional primary health care and referral to hospitals, and of course, universal health coverage. Evidence has shown that social vulnerable populations are at risk of pandemic infection and higher mortality. Therefore, many countries, though not so successful, apply cross-sectoral policy to minimize the social vulnerabilities. During the pandemic, governance is the primary entry point for a successful failure of the pandemic containment. These are the characteristics of what does it mean by good governance during pandemic. Use of evidence and science, whole government, whole society, mobilizing private sector and social capitals in the communities. Agility and adaptability and co-production are the key three key terms that contribute to a successful pandemic control. The EOC through central command and policy direction, but decentralized implementation because local government and local people know best their own local situation. Prompt decision in introduction of public health and social measures, regular social listening, which guides specific infodemic management, daily or regularly and transparent public communication will foster trust and confidence of the people during the pandemic. This is one of the critical issues and success factors. On PFM, public financial management, there's a need to improve the rigidities of bureaucracy by rapid disbursement yet ensure accountability. And also many countries apply the visual global guideline by SAGE, SAGE on many guidelines. So these are evidence generated by the visual. And some countries produce its own quick evidence for policy. For example, heterologous vaccine schedule, mRNA platform, and attenuate vaccine platform. I have conducted 4 systematic reviews. All this review has confirmed that public health and non-pharmaceutical measures were effective in reducing the transmission of the pandemic. It confirmed that non-pharmacological intervention like vaccines and treatment are cost-effective in combating the pandemic. It also confirmed travel restriction can reduce domestic and international transmission of the COVID virus. And more than 2 meter physical distancing, the full use of PPE, and avoid social gathering, quarantine, and isolation were also effective. I put a DOI so that you can review more. During the pandemic, many countries capitalize and diversify IT for risk communication and community engagement, apply for telemedicine in order to maintain and ensure access to essential health services. Many countries apply for social listening, monitoring misinformation, fact check, and appropriate rebuttal actions. In China, they also apply for health self-check and report, access to evidence, telemedicine services, and digital contact tracing. Another success factor is to ensure access to medical countermeasures through scaling up local production, adequate coverage of essential workforce to PPE, and sustain the logistic and supply chain. On funding, many countries provide financial mitigation package to the vulnerable population who are affected by the pandemic, and also significant investment, adequate response to the pandemic, and timely disbursement of the funding. Health system capacity has shown success factors. For example, scaling up diagnostic capacity, boost RT-PCR capacity nationwide by contracting public and private labs. Antigen test kit all support rapid detection and quarantine. Many countries apply rapid rollout pandemic vaccine, for which health system and or the health workforce and others to support the rollout of vaccines. To prioritize vaccination for health workforce and vulnerable population can reduce mortality in this group and maintain essential services of the country. Many countries apply business continuous plan, which maintain essential life-threatening services, for example, dialysis for end-stage renal disease with COVID and cancer treatment. Finally, many countries also apply patient triage and allocation of yellow case, mild case for home isolation, middle, medium case, less severe case were admitted in few hospitals with or without oxygen. And the most severe case were admitted in tertiary hospital ICU with many other essential equipment. So this triage and allocation will minimize the overwhelming health system. My conclusion after review on these evidences, I would say, first, don't do the wrong things during the pandemic, and do the right things before the pandemic, and do the utmost right things during the pandemic. Notably, governance is the critical entry point for effective pandemic response. And health system are key platform for successful response, and whole of government, whole of society approach are the most critical. I thank you for your attention.
Thank you so much, Viraj, for that important perspective. Our next speaker is Ruchir Agarwal from the Harvard Kennedy School in Cambridge in the United States. Ruchir Agarwal holds a PhD in economics from Harvard University. His expertise spans advanced economies and emerging markets. Currently, he is a research fellow at the Harvard Kennedy School and co-founder and executive director of the Global Talent Network. He worked at the International Monetary Fund for over a decade before that and has also been a senior advisor to the G20 Finance Health Task Force and an executive fellow at the Yale School of Management. During the pandemic, he created and implemented the $50 billion IMF pandemic plan as the head of the IMF Global Health and Pandemic Response Task Force. He'll talk to us today about the economic impact of pandemics.
Hello, I'm Ruchir Agarwal. I'll be talking to you today about the economic impact of pandemics. Before I dive into the topic, let me say I wish I could be there in person with you, but due to several reasons, I could not travel. So I'm sending you all this recorded presentation, and I'll be, of course, joining you now soon after for a live question and answer. Also, I wanted to say, why am I being selected to do this lecture? What is the background? Just to help you see a little bit of where I'm coming from. I'm an economist, and during the pandemic, I was heading the International Monetary Fund, the IMF's pandemic response, as their head of their task force, the pandemic task force. And in this context, I had the opportunity to work with various key stakeholders, both from the finance and economics community and the health community, and the multilateral institutions and governments, and the private sector. And so I want to be able to summarize some of the key lessons that we learned during this time, and also looking ahead for some of the high-level things that I believe you all should know as interested participants on the economic impacts of pandemics. So let's just dive in then. What I thought I would do is start by talking about a tale of two crises. Over the last 20 years, the world, as you all know, has gone through two very large economic shocks. The first shock was what people call the global financial crisis, or the Great Recession, which lasted between 2007 and 10, roughly, which is the first box here, this first large decline here. And then, of course, the second one, as you all know now, is the most recent, the COVID-19 pandemic shock. What you have in front of you here is the world economic growth. So how much is the economic output or income growing of the world every year? Roughly, it's been around 4% in the last couple of decades. And we saw during the global financial crisis, basically world growth went to zero. So that was a big shock. And that was a big wake-up call for the world. And it changed a lot of things. We're going to talk about that momentarily, in how we think about risks and shocks and the role of the global community or the international community. And the second shock is what we've just experienced, which is the pandemic shock. And the key message I want to show you here is, from this figure, is the shock, the size of the shock was way larger than the size of the global financial crisis shock. So yes, we lost a lot of lives, tragically, maybe close to 20 million by unofficial estimates. But also there were a lot of losses to the livelihoods of people. And these losses were larger than even the biggest shock from the financial sector since the Great Depression, which was a global financial crisis. Okay, so how did the world respond to the global financial crisis in 2007, 8, 9, 10? There was a big focus, because the shock was coming from the financial sector and from the bank and non-banking sector. So big focus on kind of addressing systemic risks or financial threats. And so that led to a very enhanced oversight, supervision, regulation of financial institutions, and a better understanding of how they're interconnected with the rest of the world. And a lot of this was facilitated because these shocks were global. There was a big understanding that we need, as global community, as international community, come together and think about these shocks together, as unified perspective. And that led to this enhanced coordination through the G7, which is a group of 7 countries, or the group of G20 countries especially. Now, the COVID crisis also highlights that the health threats pose systemic risks to the global economy, and not just a health issue. It's also an economic issue. And there are at least, I would say, 4, while the shocks are quite large in magnitude and roughly, large shocks, there are still 4 key differences, at least, that I would highlight about health threats that differ from financial threats. First is actually health threats can be more damaging to the global economy than a financial shock, as the pandemic recently has shown us, or the Spanish flu 100 years ago showed us. And while they are, maybe less or more common, we don't know yet about the future distribution, but there's huge uncertainty about the frequency of future pandemics. So we don't have a very good understanding of really how novel pathogens, new pathogens can transform with pandemic potential, can become a full-scale global crisis. And so that's kind of an additional worry, I would say. We have a much better understanding of financial risks today than we did, say, 10 years ago. Third, I would say, financial shocks there are few hotspots where they can come from because it depends on the size of the financial sector. But health threats can basically originate almost anywhere, right? A pathogen can come up in a wet market in a small country and quickly spread around the world. And so this spillover risk, and the fact that there's so many multiple weak links in the global system, makes it a very different nature and requires a much larger, stronger international cooperation. And the last thing is the cost. During the global financial crisis, cost was largely borne by richer countries. But during the COVID crisis, we saw the economic costs were much larger for developing countries. And so there's a very different distribution of who bears larger burden of the cost as well, which comes from health threats. Now, to make that point more clear on the large and unequal economic losses, here I have a figure for you, which on the left-hand side, what it does is it looks at the deviation of a country's GDP growth rate. So how its economy is growing annually. US grows roughly 2% in a normal year. China would have grown 5%. India would have grown 7%. And so this is kind of showing how do you deviate from that path? How did the global economy deviate from that path? And effectively, what you have is three lines here. The red one refers to higher income countries, advanced economies. And what you see is basically the key message there is the size of the shock for developing countries or emerging markets is much larger than advanced economies. And many advanced economies, not all, have kind of gone back to the original path. So they've closed the cumulative gap of the economic losses, whereas many developing countries are still far off where they would have been. So there's persistence of that shock. And back in 2022, the IMF, they had estimated that the cumulative losses for the global economy from the COVID shock was to the effect of $13.8 trillion through 2024. And just to give you a number, and so in a typical year, the economy's GDP is about $100 trillion. So a $13.8 trillion loss over 4 years is a very sizable hit to the global economy. And as I said already, the disproportionate impact between richer and poorer countries. Now, if you dive deeper and see which countries got hit more, so basically there's a quick overview of factors that correlate with economic outcomes in 2021. Countries that had higher reliance on tourism were hit more, but countries with greater in-country hospital capacity or public health readiness systems capacity did it better. And also countries that had earlier access to vaccines, so the vaccine doses per capita mattered a lot in making the cost less in those years. So the positive means less impact of the pandemic. And similarly, countries that have higher ability to spend, to do fiscal transfer and support its citizens in time of need also did better. And one of the lessons I think of the pandemic, which people are realizing and discussing now, is we need to be more mindful also of the real costs of lockdown, especially for developing countries where it's much harder to do remote work, and so it may be harder for bigger impact of just doing absolute lockdowns, or so maybe there's a scope for understanding what the real costs are and find a more balanced toolkit for the next time around. Okay. Let me also say there are other costs. There are hidden costs. I just talked about the immediate costs, but there are also hidden long-term economic costs, what I've called before economic long COVID. And one way this manifests itself is through learning losses for students. So this is from a piece I had done a couple of years ago, where basically we had looked at for how long were schools closed in countries around the world, and effectively on the graph here you can see basically deep red here means like 40 plus weeks of school closure time in the first year, basically March, year and a half, right? And so blue and the darker blue means very little school closing. And what you see is basically in the global south, basically where the biggest school closure impact was. And these is doubly, so school closures are roughly twice as long in developing countries than in richer countries. But on top of that, developing countries have twice as many younger people as a share of their population than richer countries. So the impact was even more magnified for developing countries. And the problem of this is we see lasting impact on learning losses and productivity of students, which basically may lead to large lifetime losses. So and a report has estimated this could be up to $17 trillion over the lifetime of these young students because of learning losses and other productivity losses. So there are also these hidden costs that we should be mindful of. Now, lastly, I just want to put one more thing. In the discussion now, in the news now, we have all seen, and we felt it in the supermarkets, the cost of inflation. We've also felt many developing countries today, and also higher income countries have higher debt burdens. So there's also difficulty with the fiscal spending. And these issues are largely also lingering legacies of the pandemic. So there are many, the main message here is, when you start thinking about the economic costs of the pandemic, you can go from very direct, narrow costs that I've shown you, and then keep broadening it to understand that there are actually many, many ways in which a health threat or a pandemic can impose economic costs on our livelihoods around the world. So last slide here, some key takeaways just for you to go home with is I wanted to emphasize that pandemic policy is indeed economic policy. It's not just health policy, it very much is both. Second, health threats and pandemics are a global security issue, not solely a development issue, but also we should think about it as a global security and a systemic risk issue. Third, there's a very strong economic case for international cooperation, as I've discussed already. Fourth, even if you think about the risk of a big pandemic like the COVID-19 pandemic of Spanish flu is about 2 in 100, so twice a century, you would still have a very high investment case for investing today in strengthening health systems and in effective preparedness, prevention, and response. And so we should be, a lot of my work is about trying to mobilize the world to pay attention to that investment case. And then lastly, just like we're doing today, there is a much greater need for dialogue between the health communities and the finance and economic communities. And I'm very glad that we had this chance to do this conversation. Thank you very much, and looking forward to the questions and answers.
Thank you so much, Ruchir. That was really a terrific analysis of the economic impact of pandemics, and the analogy with the economic crisis of 2007 to 9 was really quite eye-opening. It's now my pleasure to have all of the speakers from this really fascinating session join us, as well as my co-chairs, and Michelle Kazatskin and Jeff Lazarus, to talk about, to address our questions about the topics we've just discussed. And maybe I'll start off with one question that we have. Viraj, you talked about the importance of travel bans. And I was wondering if people might weigh in about, from their perspective, of just how effective were travel bans really? I remember in the United States when, with the initial reporting of the Omicron isolates, and we reflexively banned travels from South Africa just because the South Africans were smart enough to have detected BA1. And it just seemed like a really absurd thing to do, and as subsequent events showed, had absolutely no impact on the global spread. So wondering if people want to weigh in. Maybe Viraj, you can start since you raised that, and then I'll hear from others.
The travel ban is focusing on national level ban, so that they can contain when the surge capacity is so low. Therefore, detect, prevent, spread, and quarantine. I'm not advocating international travel ban. It must be announced by the WHO through FAIC and IHR Emergency Committee. The case of Omicron announcement by South Africa and many Southern African countries has resulted in US, EU ban of their travel and have catastrophic impact on this country economy. So I'm not advocating international travel and no way to contain the virus. So initial travel ban in a country has a negative economic impact as well.
Thanks so much for clarifying. I don't know if others want to weigh in. Anders, you have your hand raised.
Just two comments on this. I think what Viraj is saying in terms of there's a difference between national and international, but also the timing. When during an outbreak will this be potentially, possibly effective or not? I think is another aspect that is important, that when we have a big scale pandemic ongoing, big question mark whether this is effective or not. The other aspect of this, which we found during the work of the panel, is also that a lot of the decisions on travel bans, especially at the international level, had to do with political decisions, and how politicians were responding to people's anxiety in the country had nothing to do with public health evidence. So there was a different rationale also for taking some of those decisions. So when a neighbor closed their borders, the other neighbors would do the same. And I think this sort of political reality, which is we as medical people can smile at in some way, but that's part of political reality as well, that I think we need to bring into our discussion here, that there is a logic also to politics. And I think some of what we saw here in terms of travel bans actually had to do with that and not with public health. Thank you.
Thank you. Elena?
Yes, so I think I want to agree with Viraj and Anders also. First, to differentiate between the national and the international, and very, very early research that was conducted in Hong Kong, it did suggest that timing was key. But again, I agree with Anders that the evidence is not completely there. So if we have a next pandemic, I think we're going to have exactly the same debates, whether to close or not, because we don't have firm evidence.
One of the questions from a listener participating virtually is, were the health systems utilizing the data generated during the epidemic control endeavors? I guess that's asking, were we learning from the data we were collecting in real time? I'm not sure who best to address this to. Maybe Elena, you want to start?
Yes. So I think in terms, I think that's a key question, and I think it really depends on the country and the setting. I mean, I was doing a lot of work in Asia and also in Europe, and at the time I could confirm that Singapore was using real-time data, and it was quite impressive to see how they could map all the people that had been infected and who had been infected, and it was all real-time. Now, at the same time, I was also trying to help in the response in Spain. And there, I'm told that the public health group, they were actually spreadsheets and writing things on pen and paper. So I think the differences were substantial.
That's really interesting. Even in an advanced economy, there was still using very old-fashioned technology for tracking. That was certainly a problem that we experienced in the United States as well, where the CDC collects data from the 50 states and then several territories in similarly archaic modes, often by fax rather than by electronic data gathering. Another question is, what about airborne transmission? It seems like things went very wrong in our appreciation of the importance of airborne transmission. Anders, do you want to comment on that? No. Okay. So maybe I can take that. I think that's correct. It took us a long time to understand that transmission was really happening not just by droplets, but could be airborne. And that could have made a big difference because a lot of the measures around social distancing really assumed that you would have droplets that settled out of the air over a 2 meter or 6 or 7 foot distance, and that you could dramatically reduce person-to-person transmission. But when you're thinking about airborne transmission and particles stay in the air for much longer, then distancing played little role. And it was sort of amusing to see how people were still marking every 6 feet away, even though they were fully masked, at which point the distancing probably became less important. And I think it was critical to acknowledge that airborne transmission was an important route and to take those measures. Michel?
Yeah, I think there are many lessons to be learned here. And one of the important messages is that as we prepare for next pandemic, that could well be another respiratory virus, improving ventilation in schools, in all public buildings where people crowd in, will be an essential component of preparedness.
I think that's absolutely right. Anders?
No, just to add that I mentioned that the panel also raised was what we call the precautionary principle, that when one could assume that this could be the case, and there were indications at an earlier stage before it was actually confirmed, one should have taken the precautionary sort of principle before actually waiting until we had the firm evidence to be more on the safe side. And that one can discuss how do you deal with risks. Here we see that there might be a risk and we then take actions, but of course there are negative consequences of taking actions as well. But this sort of balancing, how long do you wait before you take action? And I think this whole when the world was notified that this was an airborne infection, that talks to that in some way.
Viraj, you have your hand raised.
Yes. One question to you, Michel. How do we prove whether it is airborne or a droplet? That is a question because you are quite involved in medical research. I support Anders that precautionary measures, we may say overreact rather than less reaction, because benefit can outweigh the cost. Then the counter argument is that everyone has a freedom to a free air, especially in the US, they advocate free air, freedom for free air. Then these are the politicization of the COVID pandemic.
Ruchir, you talked about the long-lasting impact of school closures. In thinking back on it now, were school closures an important measure, or could they have been handled differently, either in terms of earlier implementation of masking and potentially even testing, or certainly improved ventilation in order to keep schools open, or did school closures play an important role in helping to control the spread?
Thank you for that question. So my answer here actually applies not just to the school closure, but also to travel bans and the air question before. I think a lot of policy decisions were taken from the perspective of just the public health officials, but often we need to be very mindful that our constituents and who we are caring about there's multiple dimensions to it. So if you apply the precautionary principle just from a public health perspective, you may always go to the corner solution: shut down schools, shut down roads, shut down travel. And that may very well be the right solution in certain cases for certain pathogens, but it's often not, the corner solution is often not the right case. And in many ways, many of such policies, closing schools, having lockdowns, often hurt much more the lower income households or countries where individuals, did not have access to internet to do virtual schooling. So the real long-term costs are very different. Now, a very quick additional point there is, imagine you're a small country in Asia, Africa, or Latin America, and you are looking for guidance on what to do. What should we do with school closures? You are a responsible politician, but you have to respond to the needs for your population. It's very hard in a world in that position to make a decision. And so I think we all, academics and policymakers, also need to have an honest look at many recommendations that were made in the heat of the pandemic. Were often going to the corner solution and not necessarily taking that balanced perspective. Mm-hmm. And I think we would do a lot of good to have more research and taking an honest look at the long-term costs coming from lockdowns, coming from school closures, and have a collective dialogue when we're making that decision, which brings in the public health folks, but also the folks that are looking at the livelihoods and the education policy. Thank you.
That's a great point. If I may follow up on that just for a moment, because my brother is an economist and was asking me all throughout the pandemic, so who is analyzing the trade-offs here? Who's figuring out, what impact will the pandemic have on the economy, and what impact will our control measures have on the economy? And in the United States, at least, it was certainly unclear where that dialogue was happening. There were competing interests for sure, but I'm not certain that anybody was actually modeling the impact as you suggest. Anders, you had a comment.
No, just to say that I fully agree. So when I raised the issue around sort of taking a precautionary principle, one should think about that. But of course, to balance the risk, I think is really one of the key lessons that we have not spoken well enough about. And if I just take the Swedish examples where we did not close the schools, why? There were two reasons. One was that we saw the negative impact on children not having access to good quality education. That was one reason. But the other reasons, which was actually more important, was that if we would close the school, the parents would have had to stay at home and taking care of the children. We have quite a well-developed childcare in Sweden. And this would mainly, we saw the government's assessment was this was mainly going to affect the women. And the women are also the ones that were working in healthcare. So we saw that if we close the school, that would also have a negative impact on healthcare and health workers. And that was the main reasons why we didn't close the schools. So this was really sort of looking at the trade-offs here in between education, healthcare, service, health workers, and then what are then the negative impacts in terms of actually spreading the virus? And our assessment was that those impact in terms of spreading the virus did not justify closing the schools. So, I mean, we did that, I would say, in practice, but I think we need both more attention around talking about the different trade-offs and also more research, because in some way, if you would just lock someone in, that some countries did, of course, you could stop the spread. But there are many other negative impacts. I mean, allowing people to go out and to have some exercise, it's quite a good thing. And it doesn't increase the spread of the virus if you allow people to go out in the parks. Thank you.
One of the most absurd things I found early in the pandemic was that the park benches were off limits because people were concerned that somehow you would transmit droplets to the bench and somebody else would sit on it. In retrospect, it's easy to laugh at it, but it was really quite silly. Everybody wants to comment, so I'm going to call on people in order. Michel?
Yes, thank you. I'd like also to follow up on this and actually ask a question to you, Elena, to you, Dan, to Virosh maybe. Both Anders and Richard just mentioned the importance of research. You, Dan, spoke about how clinical trials were conducted during the pandemic in almost real time with new, innovative, adaptive designs, often when it comes to drugs and therapies. But I can't see many real-time analysis and trials going on with public health measures. Should we wear masks indoors, outdoors, always? Should we have a curfew at 6 p.m. because people crowd in the subway, or 11 p.m. because people go to bars or whatever? Every politician, every expert on radio and television had his own opinion, but for some reason we haven't been conducting those trials. Is this because it's methodologically difficult? Is it because public health doesn't have that trial culture? But for sure, we need that for the next pandemics.
Well, those are great points. Since Viraj had his hand up, I'll ask him to weigh in first and make your comment, and then I'll turn to Elena.
Michelle, thank you. We have school which is closed and which is not closed, and depends on the wave of the pandemic. For Delta, the severity is very high, the case fatality is very high, then we cannot tolerate children die because of infection. But during Omicron, some schools just open and children affected from COVID infection, just a normal flu symptom for a few days. Therefore, this a natural experiment, Michelle. I think I support Anders' statement that we have to weigh the benefit and the cost. If we introduce something, we have to understand the consequence and ready to introduce mitigating solution. For example, food supply or IT support for children learning at home. And of course, the quality and learning capacity for the poorer household is a major trouble, even in Thailand, with high level of internet connection.
Elena?
Yes. So I think on the comment that Professor Kaczynski has mentioned, I think from my perspective is one of the biggest failures, actually, I think from the academic community. I think we did very well with the vaccine, we did very well with the trials for pharmaceutical interventions. For non-pharmaceutical interventions, I think we completely failed. And during the pandemic, I realized about that, and I think we were not able to come up as a community in terms of networks, of coming up with those approaches. I think if we are honest, the people that work on trials, the people that work on health systems and that work on behavioral science, we don't talk to each other very often. So I think this is a very important lesson learned that we really need, and we were not able at the moment of crisis to really work together. And I completely agree. Now we talk, I mean, we all have to think very thoroughly. Like if we have another pandemic, the idea of do we open schools or we close schools? I don't think we have the evidence right now. Do we close borders or we don't close borders? So it was really a missed opportunity. Having said that, and trying to be an optimistic, I think now in the Lancet Commission that we are working on, we said, okay, we look at the mortality rates, but now we want to look at the long-term cost and the long-term effects, and we're going to do a similar analysis of a number of countries. So hopefully, retrospectively, we will be able to provide some solutions. But we did have a huge missed opportunity, and we have to solve that problem of networks and the experts on public health in different fields really working together.
Yeah, I think it clearly was a missed opportunity. Of course, it's much more challenging to do randomized trials that involve changes in human behavior. And even getting people to agree to participate in such studies would be a challenge. And those who participate there may be issues around generalizability because of bias of who chooses to participate. This is particularly an issue with masking. You really rely first of all on the people randomized to the intervention arm, the mask to adhere to the masks, and that people that there isn't crossover on the other side. It may be more effective to look at interventions. For example, in April of 2020, when we implemented uniform masking of healthcare workers and patients in our hospital, we saw a dramatic decline, a measurable decline in the number of cases among the staff. And so that was not a randomized effort, but at least it was maybe the equivalent of a phase 2 pilot or proof of concept study. But it is very challenging in large, especially at the population level. It's almost easier to do matched control studies or maybe community randomization studies are potentially doable in that setting. Anders, you have your hand raised.
No, just a very quick one. Given that, then it's very interesting that we still, and including WHO, is recommending masks in the general public. That we do it in hospitals, healthcare centers, absolutely, we have evidence. But to use it in the public, what evidence do we have for that? I'm still not convinced that we have enough evidence here, but I will be happy to read and to study more. But I mean, it's interesting giving exactly what you said, but that was basically what happened across the world. That masks in general public is an effective measure to stop the outbreak. I haven't seen the evidence.
I think that's a really interesting point because, from the U.S. perspective, first of all, we would see that pre-vaccine, the blue states, the states that were more likely to adhere to a public health message, where masking was more widely implemented and where other measures were more widely adopted by the population, they tended to, after the initial wave, saw lower rates than we saw in the southeastern United States and in the Midwest. Now, maybe that's because the epidemic was simply moving and these populations had now become immune and so the virus moved on, but it could also be that because there was real uniformity and unity of approach between the healthcare sector, government, public health authorities, and the highly educated population that really adhered to that. The other thing that we saw from the U.S. perspective was looking at Asia, and you mentioned the successes in Singapore, but also the early successes in Taiwan, Hong Kong, South Korea, where masking is a cultural phenomenon. They really had much lower rates, at least early on. And so I think there is circumstantial evidence. Now, whether that is ironclad or really high quality evidence, I certainly wouldn't claim that it is, but I think there is circumstantial evidence. And then it depends, of course, on the setting. It was absurd for us to be masking as we walked outside on the streets, but we could probably have not shut down most of the economy. For example, there's no reason retail couldn't have remained open. There is no reason manufacturing and most businesses couldn't have stayed open if people were masking while they were on public transport and while they went to work, because they wouldn't have had as much risk of transmission. At least that's one perspective. So. Another question that we received from our audience is, did the global health security agenda fail during the pandemic? Wonder if someone wants to. Elena, do you have a comment? No.
Well, the Global Health Security Index.
Yes.
Maybe, Elena, you could
Yes.
comment on that.
Yes.
Yeah.
So one thing is what I provided in my presentation, the fact that we do have some indexes that measure whether countries were prepared or not. And the most well-known is the Global Health Security Index. And what it measured was the capacities of countries in a very narrow way in terms of whether they're prepared or not, and very binary. And what we've learned through the pandemic is that key aspects that we've mentioned, and I was very happy to see that we agree on most of the key aspects: leadership, community participation, trust. They were not able to measure these issues. So it's not enough to have all your capacities in place if then you don't have appropriate leadership. It's not enough to have wonderful pandemic plans if afterwards you're not implementing them. So I think in that case, we need to revisit, and that's why I think it's very important that we think of what were the key components and to really strengthen countries' capacities based on that, what we call more qualitative components, which again is an area, behavioral science, scientists, qualitative researchers, they were not involved in this part of developing these indicators. So that's another lesson learned. I mean, as a positive, I would like to say that it's true that now we are learning much more to work together. And that universities, for example, that traditionally would not hire health systems experts, now they're moving towards hiring this type of expertise. So I think we are moving in the right direction.
Ruchir.
If I could just broaden the definition of global health security to global security and make a point about the world's response as one of the things we learned in the pandemic, that in a very difficult moment, the world can potentially come together and act as one in certain aspects. So we did end up raising $20-30 billion on behalf of developing countries. We did end up overcoming for a while at least fragmentation between the public health agencies with the ACT Accelerator and even the Multilateral Leaders Task Force that I helped create between the IMF, World Bank, WTO, and WHO. And I think that's something we should really learn from, that we have a technology that allows us to cooperate, at least in very hard times. Now, we are again going back to a world where cooperation is quite hard and maybe even harder than before the pandemic. And I think we have to think hard about what can we do together to preserve some of those abilities to cooperate. And one thing where we did not do well at all, and this is a big risk for global security, is speed of financing. And this is an area which I call day zero financing, which is we need to have more money in place to respond to the pandemic on day zero of the next pandemic, not wait for 2 years to raise the money to fight the pandemic. We also had quite a lot of difficulty on the trade side and closing of borders for critical countermeasures. So there are issues which we can learn from this pandemic and invest today to strengthen the global security to address future threats.
A great point. Anders.
No, I agree with Ruchir, and I really liked your presentation. It was really, really good. But the question is why we are then forgetting this, and why isn't the world taking action? I mean, your arguments are so strong, but what we see now, forgotten. What we did with the panel, the first thing we did was to review 16 previous commission. Things have been said, recommended, no action. So, I mean, and your economic arguments is massive. But still, we are not investing in preparedness well enough as it is now across the world. Are the countries learning, investing now, preparedness? No. Or do we have an international system now that is basically building on what was done on the financial side to have stability in the international banking system, to have a stability now in the international health system, and having something that is not just depending on aid? I mean, we're getting tiny resources compared to what we need, and it's just depending on some donors' willingness to put some money. That is not what we need. This is not about aid and development. This is about global security. And I will use your slides. Really, really good. But the question is still why? And I suppose this is coming back to my sort of political economy, that politics has its own rationale. You can only deal with one thing at a time, and to using those strong arguments that you're getting and you're providing, it's difficult. Long-term investments is much more difficult than the short-term paying for the crisis, even if that's 100 times more expensive. But I think for me, it's very frustrating to see that we have the arguments, we have learned the lessons, we know what needs to be done. I mean, in terms of the speed, both when it comes to money and also access to diagnostics and vaccines next time in a better way, we know what needs to be done. And I was possibly, Virosh, a bit too pessimistic about the pandemic treaty negotiations. I hope you will succeed. But still, I mean, we should have this done by now. But for some reason, then, still, the arguments are not strong enough.
If you allow me to just respond very quickly,
yes,
I would just like to say I loved also your presentation, Anders. So I feel my big agenda here is we should make the argument not from a development perspective, not from the goodness of the heart. These investments are in the best interest of every country, especially the high-income countries. So a lot of the work we should do collectively is to make that investment case and treat it separately from official development assistance. This is an additionality. There's additional investments needed. It's very different than investing to help for refugee or humanitarian assistance. This is really in every country's self-interest. And if you take the amount of money that we are looking for, it would be beneficial, basically many times more for every individual country who would contribute to the global agenda. So this is a global security agenda. That's why I wanted to emphasize that in the context of global security.
Viraj, please.
Thank you, Anders. I'd like to provide my reflection as Vice Chair of the INB Bureau, who steer the negotiation of pandemic accord. And take into account last week here in New York, the political declaration of PPPR. I see I'm quite not that optimistic. From the Geneva negotiation, it's quite pessimistic in the last 6, 7, 8 months. There's no good faith to rectify the global inequity that we learn. And the economic recovery is very poor in low-income and middle-income countries than the high-income. As Ruchi has presented, your argument is very strong, but why politicians, the G7 or G20, seriously take into account and rectify to improve the global security, not global health security, is security for everyone. The real negotiation will start next month, November, December, and only 2 more negotiations in February and March before May Assembly to adopt. I see a huge deadlock in many provisions, in particular access to pandemic response product in a timely manner. World North is so divided with the global South perspective. So I'm quite pessimistic, but we will do our best to steer the maximum we can do.
Elena?
Yes, I wanted to make a couple of reflections more from a researcher perspective, having had the opportunity to research at the national level, but also at the global level, and learn from Anders, Viraj, and Professor Kaczynski in terms of operating in the global health world. And one point for me, and Anders mentioned that, he said there were all these reports and those recommendations were not followed up. And I'm worried that it's going to happen the same with the recommendations from the independent panel. And part of me, when I went back as a researcher, is who was to blame? There was no single research on that. Who was to blame for those recommendations not being implemented? And there's a lack of expertise on that because it's very difficult to do research on those areas. But I feel if there was accountability, we need accountability mechanisms that these people are made accountable. If this is going to fail, it's because this person did that, this person did not do that, this organization did not put their weight. I mean, I think this is important, and it's an area that maybe in global health we should consider a bit more. In terms of very quickly making the economic case, I really like what Rashid mentioned, and I'm always trying to think of different approaches because I have to admit that when I talk about global health issues to a constituency, like more at the national level, unfortunately, nobody tends to care. So when I, just to give an example, when I make a tweet about a global health issue, I get 1, 2, 3 likes. When I used to make a tweet about the national Spain, I would get thousands of likes and thousands of, so I think we also need to think what the population cares. And what I found an angle is to, I think all countries agree that they have to reform the health systems. All countries, the population are asking governments to reform the primary health care. They're asking them to make changes. And I find that we have to come from all corners. So the way that I see for pandemic preparedness is to say, your country has to improve the health system, it has to link with public health, and it has to link to pandemic preparedness. It's not an easy task, but I think all approaches could be helpful.
I know Viraj has his hand raised, but I wanted to pick up on one comment that you were just making in terms of improving the health sector in countries. One thing that countries seem incredibly reluctant to do, and this is particularly the case in the North, is to build in any surge capacity. There's no elasticity or ability to expand the response when, even though we were successful in meeting the needs of people with acute COVID, that was at the expense of deferring health care for other people with often critical health needs. And there's no willingness to allow for there to be excess capacity in the health system, both in terms of real estate, as far as hospital beds and so forth, but also as far as personnel. So, Viraj.
Thank you. I'd like to ask a short question to Ruchi. Your 13.8 trillion economic loss, which is 13.8% of global GDP, did you take into account human capital lost on this? Because we have million people die, and also the visual estimate. The last estimate is in middle of this year. A huge excess debt during the pandemic 3 years. Did you take into account? If you did not, this 13.8 trillion will be a lower estimate, so that you can justify a more economic case of a pandemic strengthening.
Dr. Viraj Kapunkar, thank you. Yes, it's only the narrow GDP loss. It does not take into account about 20 million estimated deaths. It does not take into account the cost coming from long COVID, which may be lower productivity among millions and millions, hundreds of millions of people. It does not take into account the lost productivity and learning losses, which could be in the trillions of dollars. So yes, it's a lower estimate. Yet I would like to emphasize that number 13.8 trillion, which was actually very impactful, because the financial markets, the economic sectors, they are looking narrowly often at what's the GDP impact. And so even the huge number of 13.8 trillion is sufficient to justify large investments in preparedness, in surge capacity, as was mentioned earlier. And so that's why we can clearly delineate those costs.
It seemed also that the flip side of not having surge capacity is that industries that laid off large numbers of people then were shocked to find that people wouldn't come back to work when the pandemic resolved, and we had lingering delays in air travel, in the food sector with restaurants and the hospitality sector, because employees who were so easily shed were now not so willing to return. I wonder, Ruchir, if you have any thoughts on that.
Yeah, I think that's a super important point, because in many ways, if you see, a lot of the lingering effects of the pandemic are really the key issues today. Inflation, one of the highest inflation many countries have seen in decades, and that really has political implications as well, has led to government changes. Then the huge labor shortages, and across the world, not just in the West. And then I would say the third thing there is a lot of geopolitical fragmentation. There's a lot of distrust that has come between countries, because countries have realized that in times of need, we cannot rely on certain countries as partners. There's trade barriers put up. And so I think we have to work through a lot of these things with wisdom, in a way, to both repair on the economic side, but also make sure that the geopolitical implications, as Anders also highlighted earlier, are really do not spiral out.
Any last comments from members of our panel?
Yes, my final reflection is that I found this conversation really fascinating, because we've moved away from only talking about health, but also talking about the economic impacts and the social impacts, and this very rarely happens. And I think the next step is also to integrate the health of humans with animals and the planet, and then the circle will be complete.
One health.
Yeah.
Michel, any comments?
Absolutely. I would also add the geopolitics, as Richard just mentioned, and that came several times in Anders' talk. That is an issue that we have to take into account.
Well, I'd like to thank Ruchir, Anders, Viraj, Elena, and my co-moderator, Michelle. This was really a fantastic session. I think it touched on all the points we hoped to raise and went beyond. And I think this is a great way of launching this lessons learned workshop. We're going to be taking a break now for approximately 15 minutes until 5 minutes after the hour, and then we'll resume with session 2.